Really, what I was thinking about was just the insidious nature of neuro injuries, right? There were so many times where, you'd have patients in the neuro ICU and folks that didn't normally come into the neuro ICU. What do you want to call it? Realm too often, just didn't have an appreciation for that injury. It's kind of that silent, insidious injury. You look at somebody, they seem fine. I think families are the same way. They look at their loved one who's had an injury, and they just seem fine. So that's kind of where I was thinking. Just how I really appreciated how you were talking about. It just takes such a trained individual, and then you started getting into being an active participant in the healing therapies. Some I hope you get into more. Some of the therapies that you see for other injuries. You're kind of a passive participant, if you will, but with neuro injuries, you've got to be involved from the minute, those therapies start. And it's a lot of work to get well from a neuro injury. So it sounds like you're getting ready to get into that a little bit more. So
I guess my comment on that, Kylie, again, is as we think through the background that we share, coming from the neurointensive care unit, we come from the background where data is key. And we're being fed tons of data. Remember that? Like being fed, data related to vital signs. We're being fed data related to, remember even in the ICU, the eyes have it, especially in the neuro ICU, mm-hmm. The eyes have it. A lot of information from what the pupils are doing. You may have a patient with a massive brain hemorrhage or a massive stroke, but think about all that information that the eyes contain. Mm-hmm. So I carried that to the outpatient world with that same mindset. A lot of data, helps us make important decisions, actionable data. It needs to be actionable. At the same time, I carry that simple statement. A lot can be seen in the eyes. A lot can be seen, a lot of information. Before a patient with a massive brain bleed, before they herniate, or even as they herniate, as the brain, the swelling progresses and the brain is shifting from one side to the other side or going into the, the foramina, the pupils will tell you a lot. So we actually do pupillometry, pupil size assessment with certain devices that can help us. It's same principle on the outpatient side where perhaps not herniation, but then we're getting a lot of information when we do vestibular ocular testing, and apply that same principle, data that's actionable. So that's again, so I become that strange neurologist who wandered into the neurointensive care unit and found a love in the neuro ICU, and then came outside carrying those same principles. Data, actionable data, and then data we can do things about, because that's how our training is in the intensive care unit. Data that you can do things about. So in that diagnostic paradigm, if one wants to think with the technologies that we have available, if one wants to go beyond, let's you had a concussion and that's about it. Mm-hmm. We can look at things such as, you had a concussion, what has been impacted? So that, that information on what has been impacted will steer us to how do we help with those, with those impacted systems. So we talked about eyes. I'll tell you something else that I found quite interesting. And in that navigation, as a neurologist, we knew it. We talk about it. We talk about, that really in-depth neurologic exam, including olfactory testing. So testing smell. And again, it pleasantly surprises me, even in this side of things, how little conversations on taste will tell us about that neurologic event, that brain injury that's been suffered. How does food taste? Oh my goodness, the things I used to like taste horrible. They taste like cardboard. Yeah. And then take that further and perform certain smell tests, certain olfactory tests. University of Pennsylvania have, they have, there's a certain smell olfactory battery that really helps you tease out smell function, and that quite often is dysfunctional, but we don't realize it till we test for it. So again, just ways of putting together objective evidence that a traumatic brain injury has occurred. So for me, importance is actionable. So why are we getting it? Is it actionable? And that comes from that ICU thought process. Again, looking through more advanced, not everywhere available neurodiagnostics is electrophysiologic, so brain electrical testing. And Kylie, in our world in the intensive care unit, it was EEGs. We used to look at EEGs, brain electrical maps and electrical signatures. In that world, though, and in many other situations, as practitioners of neurology, we would say, is there or is there not a seizure based on that brain electrical map?
Right.
But there's other information in between. Is there or is there not a seizure? And there are certain signatures that research is telling us, signatures of brain injury, where we look at, for example, present some information, auditory or visual, and see how that information is received, transmitted, and processed in parts of the brain. Now, those are called evoked responses. And yes. those are many times dysfunctional in concussed individuals. And many times that dysfunction correlates with these vague complaints. My memory just isn't the same. I keep asking the same question. I feel as though it takes me 10 times longer to study through these things or even to read. It's cognitively fatiguing when we look at those electrical signatures, the evoked responses. So that's part of what I also use in that armamentarium in some patients, that can also be off. So again, actionable information, when you start to detect certain signals or signals such as that, then again, it can guide you on where do we go from here. Should it be some form of cognitive therapy? Should it be some form of speech therapy and things of that nature? So again, we're talking through what's that diagnostic process, and then can we get actionable information, besides saying it's a concussion. And then so
Dr. Mbeo, if I might interrupt, fascinating stuff. So I know even in the neuroICU unit, all these, I like how you call it actionable. It's objective data, right? It's not something that you can just tell me about. There are things you can see. There are things you can observe, whether it's in data or in body responses, pupillary responses. I loved your mention of the biomarkers. It also, I know when we're in the hospital, you're doing successive assessments. Do you find yourself needing to do that on the outpatient side of things? You do one base, initial assessment. You have to bring the client or the patient back every so frequently to do that sort of thing?
That's a great question. Now, the battery can be it's a tiring battery to administer. In fact, many times will take days. I make it sound as though this is something we will do in one day, but many times will take days. When I do that serial assessment, I pick it in certain patients. I'll tell you, for example, I had one young man that I saw today whose last biomarker and not just blood, but also, physiologic biomarker assessment was probably about 4 months ago. He feels better in some ways and maybe not so in other ways. And as we talked through it, what I told him was my approach would be, let's pick a couple of things and then perhaps repeat them to tell us what direction, you feel better in some ways, maybe not so much in others. Let's repeat a couple of these tests and see, do we have an objective demonstration of change? Do we see better, worse, or the same? So in some cases, I do repeat it again, but with a reason, such as this individual today. The serum biomarkers certainly can be repeated when I see them really elevated, which many times the GFAP and UCHL1, many times those are dramatically elevated, and that also sometimes will correlate. It'll correlate with the neurologic symptoms as time goes by. Again, just to demonstrate a correlation with their improvement, we might repeat it. I say, hey, let's repeat your biomarkers and see, if this matches up with exactly how you're feeling. So that's a good point. That's a good question. One question might be this, Dr. Mbeo, I haven't heard that MRI, and I'll tell you, many times I get that question. I get, Dr. Mbeo, that cannot be a very comprehensive evaluation because I didn't hear you say CAT scan and I didn't hear you say MRI scan. And so CAT scan, for the reason we talked about. So the CAT scan is a good acute, fresh traumatic brain injury, acute evaluation tool with a specific question that we're asking. Is there or is there not a bleed? Is there or is there not, a significant new thing or a significant thing in the brain? That's the role of a CAT scan in many of these cases. Now, as we think through that, the longer or the higher value information, it'll most likely be in an MRI scan. And then, even then, if we're looking at that, a concussion, and then the role of MRI scans, many people will say, well, between 30, 60 days, you may start to see changes on diffusion tensor imaging. So perhaps if there's no acute reason to check, perhaps wait until that point in time time. I say that again with that little hesitation you hear in my voice, because DTI is not universally available. DTI is diffusion tensor imaging. So a very sensitive way of assessing these sensitive neuronal pathways, these tracts, these pathways of neurons that are prone to what's called shearing injury and axonal injury. So diffusion tensor imaging is a way we're able to track those pathways and identify disruptions in those pathways. So quite useful as a tool, not universally available. In 2024, I suspect as time goes by, we'll start to see that more and more available. So even then, just that routine MRI might have utility. I tell my patients that for some reason we're getting an MRI for whatever evaluation. I say, well, a negative MRI did not or does not rule out your traumatic brain injury. In fact, if it was just that routinely performed MRI, the way we perform most of our MRIs, I wouldn't be surprised if it didn't show us anything. Doesn't mean you didn't have a traumatic brain injury. I've had many situations where we had that, call it normal MRI scan, and then when we go through, when we use a DTI capable MRI scanner and take a look at those subtle changes, that is the point where we do detect those changes. The diffusion tensor imaging will show it. So that there's a role for neuroimaging for sure. My hope is as time goes by, as our understanding gets more sophisticated, we get more standard protocols and just availability of these protocols will be more universal. But in 2024, it remains a clinical diagnosis with all these ancillaries we've talked about.
Yeah. No, you mentioned, the MRI. We have, being in the nursing, the clinical side of things, and then, going over to this side on the legal side where they're now clients. Especially the brain injury clients. I've found DTI. I'll be honest, I was not familiar with diffuse tensor imaging before leaving the bedside. It's not a hospital tool, right? It's not an acute setting tool. Found myself fascinated with that. But the problem is, you're right, it's not universally available. There are clients, if they have the capacity to travel, they may be traveling, to a different state to get these things. So it sounds like you see that becoming more readily available, correct?
That's correct.
Sensor imaging.
That's correct. So diffusion tensor imaging. So certainly we're at a time now where many locales will have it, certainly more than if we were having this conversation even a couple of years ago. But I'll tell you this, the gap in that ability to use advanced imaging such as DTI and say functional MRI, which again is becomes the availability issue. The gap, my hope is that gap is being filled by us reaching for these other low-hanging diagnostics. Let's talk about certainly biomarkers. So GFAP and UCHL1, certainly vestibular ocular testing. So a good vestibular ocular assessment tool, and including just clinically, and then using equipment and all the way up to VNG. The balance testing, all the way from the straightforward bedside balance assessment, the ROM bag and some balance assessment tools we can use at the bedside, all the way to more sophisticated computerized dynamic posturography. So that to an extent starts to fill the gap of lack of imaging, and then put all that together with the history and put all that together with the clinical course of this individual. That helps us understand a concussion, yes, indeed, did happen, and let's do this for that concussion.
Exactly, yeah. And then on this side of things, having your expert, feedback, your diagnoses available, and having that objective data, only helps to further, bolster a client's case when they're trying to put forth, I was, seriously injured, these are, this is the data that I have to prove that now. And so that's really exciting, when we get on this side of things, when clients are trying to, receive, rightful compensation for somebody's, terrible error at their expense. So this is wonderful.
Absolutely, Kelly. And to speak to that, the palpable injuries are, neck, back, shoulder, knee, and imaging that's able to detect injuries in those areas. Those are palpable. That's easy to say, well, hey, I see these changes in the cervical or the lumbar spine, or this rotator cuff pathology that could only be. So those are palpable, and many times these brain injured individuals do not have, and they may have the palpable injuries, but in equal number, there are, like the particular young man I had a conversation with at his clinic visit earlier today, but same thing. He doesn't have those same palpable injuries, but it doesn't take away from the fact that he has a significant injury. What makes us us? It's our brain. What makes us us as that the unique ability that we have as human beings is this really important organ we call the brain. And fine, I could live with a rotator cuff injury. It'll hurt a lot, but take away my brain, and that takes away my ability to interact with the outside world. This particular young man, for example, as much as did not have many of those other profound deficits, had a brain injury significant enough for him to have to drop out of school. And he says, what, Dr. Mbeo, keeping up with my classes is no longer as straightforward. I used to ace my classes. Now I'm having to study much longer. I can't retain. I'm failing tests and things of that nature. And then he had to actually step out. And think about that. If we go by the usual metric, are there disc herniations? Are there rotator cuff changes or knee changes? Well, no, there's none. Well, he must not be injured. But think about the consequences of this injury. This really talented young man who came in with the abilities that got him into this level of academics, now having to pull away from this level of academics.
Yes.
And what's that going to impact, as far as his future?
Yeah, maybe a little reductive of me, but you mentioned a good point. You've got these disc herniations, a blown out knee, a torn rotator cuff. Those are you can put a dollar amount on that. For example, how much it may cost to treat, an issue like that, and should get relatively back to your baseline. But a brain injury, you could be talking a lifetime of change. I mean, you could be talking personality change. Maybe you can't do the job you did. You're a high, functioning CEO. You're not going to do that anymore. I mean, you could be talking lifetime impact here.
Absolutely. Yeah. In subsequent discussions, we could always talk about where do we go with all that information. So we've made the diagnosis. In fact, part of that hesitation in really going deep into diagnostics is fine. You'll find it. Where do we go from here? And I'm happy to talk through where the world is taking us, where we are now and in the future in terms of rehabilitation.
Okay, well, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Thank you again to Dr. Mbeo for coming by and speaking with us today. We got to hear a little bit more about some treatment strategies and got into some novel therapeutics. So again, remember to hit like and subscribe, and then hit that bell for notifications on our latest and greatest content. And as always, please remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.